My dear friends, in this video, I'm going to talk briefly about what is refractory shock and how to approach such a patient. So before going into the subject, it is important to understand the terminologies which are associated with refractory shock. Refractory shock is defined as a persistent hypotension with end organ dysfunction despite fluid resuscitation, high dose vasopressors, oxygen, and ventilation. And all types of shock, whether it is hypovolemic, cardiogenic, septic, they can all progress to refractory stage, and it is refractory shock. But once it becomes refractory, it manifests as a vasodilatory shock because there is impaired vasomotor response. So despite the use of vasopressors, there is no constriction and it continues to be in the vasodilated state. And this impaired vasomotor response is caused by reduced responsiveness to vasopressors, excess of nitric oxide, and lack of vasoconstrictor hormones. So if a patient is on refractory shock, the strongest predictor of mortality is the vasopressor dose that is required to maintain the mean arterial pressure. Higher the dose, higher is the risk of mortality. It is important to understand the concept of norepinephrine equivalent score in intensive care as a marker of the requirement of in the shock severity, because that explains in case of other vasopressors. So whenever we use other vasopressors, that can be converted into the appropriate dose of norepinephrine equivalent by multiplying with a factor. And that factor is different for the different vasopressors. It is similar for epinephrine and norepinephrine, but for all others, it is particular factor. For example, with vasopressin multiplied by 2.5, with angiotensin 2, it is multiplied by 0.0025, terlipressin multiplied by 10, methylene blue 0.2, etc. So all these drugs have a norepinephrine equivalent and the same can be calculated. Now, the important thing is to know that what constitutes a high dose. So it is generally speaking, most of the studies, although the exact definition is not there, the high dose of vasopressor is one which can be defined by converting other vasopressors, or if noradrenaline is used, only noradrenaline or norepinephrine, that is, or in equivalent amounts of more than 0.2 mics per kg per minute. Because we know that the range is quite wide from 0.2 to 5. So often we don't consider 0.2 mics as high dose, but in reality, in the definition that is provided, in most of the studies use a dose of more than 0.2 micrograms per kg per minute or norepinephrine equivalent as a high dose. And once we know the high dose, we can roughly have an idea is the maximum permissible dose. So there are two concepts. One concept is that there is no maximum permissible dose because the dose response curve shows a rise followed by a plateau. It doesn't show a decline. So the proponents of no maximal permissible dose, they advocate that it is not going to be any harm. Whereas some people say that if the dose is too high, then as such, despite there not have been, but the requirement of the afterload requirement, the amount of it is required so high, so that can produce a shock. So that is called the vasodilator induced shock or vasopressor induced shock. So whatever may be the factor, we usually accept a dose which is more than 5 mics per kg per minute as the highest permissible dose, or in other words, in simple calculations, the dose more than 300 mics of norepinephrine going, or more than 100 mics per minute of epinephrine going, is considered as a maximum permissible dose. There is one more score which is used to quantify the degree of cardiovascular support which is provided by the vasopressors and ionotropes, and this is called the vasoactive ionotrope score. Although this vasoactive anoscope has been largely confined to cardiac surgical patients and to some extent in other cardiologic patients, this has been validated some in as well as in other studies, in few studies in certain other groups of patients, and there it has been found to be a useful parameter and it can be used. So wherever is used, we should we should know the factors which are responsible, and we should calculate in a similar manner where we calculate the norepinephrine equivalent dose. But in this case, in addition to the dose, there is a point systems are ascribed with each of these drugs, with dopamine, norepinephrine, phenylephrine, vasopressin, etc. 1, 2, 3, 4, etc., depending upon the dose. So if the dose is of epinephrine is between 0 to 0.05, it is 2 points, 0.05 to 0.1, it is 3 points, more than 0.1, it is 4 points. And when the calculated vasoactive inotrope score increases, a higher vasoactive inotrope score indicates a greater need for CVS support, and it is a predictor of poor outcomes in certain populations. So whenever a patient is having refractory shock, first of all, we have to assess the cardiac output and check for the fluid responsiveness. So this can produce four situations. One, patient may have a low cardiac output and can be fluid responsive. Patient can have a low cardiac output and may not be fluid responsive. Patient can have low cardiac output and plus or minus fluid responsiveness, that is, maybe, may not be, or patient may have a high cardiac output and plus minus fluid responsiveness, that is, may or may not be fluid responsive. Now, if the patient is having low cardiac output and positive fluid responsiveness, the patient is in hypovolemic shock, and the causes of hypovolemic shock need to be excluded. And it should be followed by diagnostic tests. The hemoglobin, identify the suspected bleeding site, cardiac filling pressures, fluid challenge, blood transfusion, and if the patient is bleeding, so on and so forth. If the patient is having low cardiac output and fluid responsiveness is negative, then the patient will be due to cardiogenic shock. Again, the causes of cardiogenic shock need to be excluded one by one, followed by the diagnostic tests, ECG, if the patient is having PA catheter, or if there are non-invasive cardiac output measurement, the same can be done. Can consider inotropes or consider mechanical circulatory support. If the patient is having low cardiac output with plus minus or indeterminate type of fluid responsiveness, the patient should be in a state of obstructive shock, like cardiac tamponade, tension, pneumothorax, pulmonary embolism, etc. And in each case, the condition should be excluded, and that should be followed by the diagnostic tests in the form of chest X-ray, pleural ultrasound, echo, blood pressure, etc. If the patient is having high cardiac output with plus minus fluid responsiveness, then the patient is already in vasodilatory shock. Sepsis is the prototype of vasodilatory shock, but there are other causes of vasodilatory shock too, like anaphylaxis, sedative or vasodilator drugs, protamine reaction, propofol infusion syndrome, etc. And then also the condition has to be excluded based upon clinical exclusion, followed by the performance of the necessary diagnostic tests, blood cultures, procalcitonin, ionized calcium, blood gas, etc. So followed by discontinuing the offending medications. And if it is septic shock, we have to consider appropriate antibiotics, increase vasopressors, etc. Mortality in refractory shock exceeds 50%, and almost 6 to 7% of critically ill patients in the ICU at any point of time may go into refractory shock. In the management of refractory shock, it follows a continuum. As you can say that in increasing order of shock severity, we have the strategies like in early shock, we have to identify the underlying cause, resuscitate with fluid, and start norepinephrine monotherapy. But all this are usually over by the time a patient becomes refractory. So in refractory shock, we have to identify the treatable pathology. If we have been able to identify the same, or till the time we can identify, we have to continue with rescue therapies. Two rescue therapies are often highlighted. One is the methylene blue and hydroxycobalamin, which do have some role in some cases. The combination therapy, combining different vasopressors and adjunctive therapies may be necessary to achieve tissue perfusion when the patient is in refractory shock. It is good to know that early intervention or aggressive intervention before the shock becomes dominant refractory state lasts for a long time can improve outcomes. An individualized approach is always better and brings a good outcome. So strategy should be tailored to the patient's condition and after determining the underlying cause of shock. And of course, there are emerging therapies such as nitric oxide inhibitors, methylene blue, which have been found to be useful in selected populations. So what is the role of steroids in refractory shock? Corticosteroids may improve shock reversal by stabilizing the cell membranes, enhancing the effects of catecholamines, and improving tissue metabolism and oxygen utilization. There are significant potential benefits, and the studies suggest that they may reduce the time to shock reversal and improve the hemodynamic status overall. But they do carry the potential risks of hyperglycemia, hypernatremia, or neuromuscular weakness. So hydrocortisone can be given 100 milligram or 50 milligram every 6 hours. It is the usual dose, or they can be also given 100 milligram 8 hours. Usually, whenever a patient is more than one inotrope or vasopressor, it is routinely administered. We have to know regarding the usefulness of methylene blue in refractory shock because this is a cheap drug. It shows promise in a lot of situations. The mechanism of action of methylene blue is the inhibition of the nitric oxide cyclic GMP pathway, reducing vasodilatation and increasing the vascular resistance. So it has got definite vasopressor sparing effect, and it reduces the dose of the conventional vasopressors by reducing vasodilation, and that decrease in the dose of the vasopressors requirement by the patient is beneficial long term, helps them get weaned off from the vasopressors. As an adjuvant therapy in septic shock, when vasopressor requirements are more than 15 mics per minute of norepinephrine or norepinephrine equivalent, or patient is on multiple vasopressors, this can be tried. And the common approach involves a bolus dose of 2 milligram kg over 15 minutes, followed by a continuous infusion over 3 to 4 hours. How does CRRT help in refractory shock? CRRT is one of the most important invasive procedures which can give a respite in many cases of refractory shock. It allows rapid control of temperature and correction of metabolic acidosis in such patients. It also contributes to a reduction in the vasopressor requirements and improves the cardiac output. There may be some amount of removal of antibiotics and vitamins or trace elements for which they require supplementation, and the same can be done after completion of the CRRT in the full dose. When should ECMO be considered for refractory shock? There are certain indications in adults which are different from neonates and pediatric patients. In adults with hypoxemic respiratory failure, when the PF ratio is less than 80, despite optimum conventional treatment, including a trial of prone positioning, we can consider ECMO. Hypercapnic respiratory failure, pH less than 7.1, despite optimal conventional mechanical ventilation, we can try respiratory ECMO. And besides this, there are certain cardiac conditions like systemic systolic pressure less than 90 or MAP of less than 70, despite adequate fluid resuscitation, vasoactive inotrope score, which I have mentioned, more than 50, that is at 1 hour, or more than 45 at 8 hours, urine output less than 30 ml per hour, lactate more than 2, cardiac index between 1.8 to 2.1, SVO2 of less than 55%, altered mental status, all are indications to consider ECMO in patients with refractory shock due to cardiac conditions. It improves myocardial function, and it is used in all patients with refractory cardiogenic shock. So my take-home message would be that refractory shock is a vasodilatory shock resulting from impaired responsiveness to the catecholamines. Evaluation should focus on the identification of the primary cause and reversible secondary contributors like hypovolemia, pump failure, or obstruction that is responsible for the shock. And various rescue treatment options are available for refractory shock that have been described to benefit the hemodynamic variables, but none of these therapies have shown any reduction in mortality so far or have been proven to be superior than others so far. Thank you.